Y'all good? How's everybody doing?
Good.
All right, good. I'm doing great. So you notice I'm in purple. That means I'm usually at work. So I'm not at work. I'm down here with y'all, which means it's a great day. So I'm happy to be down here. So just so y'all know, my name is Zack Marcus. I'm a critical care clinical pharmacy specialist at Renown Regional Medical Center. That's a whole lot of words to say I'm a pharmacist, and I spend a lot of time in an ICU. I spend most all my time in the trauma ICU, some time in the ER, some time in the CIC, and a little bit of time in the medical ICU. But my primary role is in the trauma ICU with the trauma doc. So we have the opportunity to take care of a lot of people that you bring us, and y'all do a really good job. So I'm here to answer any questions that y'all have about meds or some other stuff and provide you a little bit of information from our perspective, what we do at the hospital, and what you may be able to do here, depending on what meds, because we're going to talk about vasopressors first, you have and how we like to use them, how you may be able to use them in your practice, okay? Any questions to start with? All right, good. So we're going to start with just some basic stuff, right? Y'all all know this. This is all really basic stuff, but we're going to start here. So when we talk about vasopressors and inotropes, right? Vasopressors are drugs that will work on the vasculature. And in order to work on the vasculature, typically you have to have some kind of activity at an alpha receptor. So your alpha 1 receptors are the ones that are primarily associated with vasoconstriction, so squeeze, right? So when you activate those, you get an increased blood pressure theoretically because you're squeezing harder and you're actually creating a smaller hole for the blood to go through, right? So you're going to increase your blood pressure. The alpha 2 receptors are often seen in the CNS, right? So is anybody here familiar with clonidine? Ever heard of clonidine? Ever used clonidine? This is how clonidine works, right? Clonidine is an alpha 2 agonist. Well, what does that mean? That means a couple of things. Clonidine, being an alpha 2 agonist, works in the CNS, and the alpha 2 receptor is on the presynaptic neuron at the very end. So what it is, alpha 2 is basically, in most cases, considered to be a feedback receptor. So what happens is you have enough of whatever neurotransmitter it is floating around out in the synapse, getting ready to bind to either your heart or your lungs or whatever receptor it's going to go bind to, right? Well, what happens is you have enough of it, and it gets back to that receptor on that neuron. And what it does is it tells that neuron, hey man, we got enough. Don't send any more out. So really, it's a negative feedback receptor. So alpha 2 agonists will also decrease blood pressure. They will decrease it, not increase it, because they're stopping all of those different things from coming out. All of your norepinephrine, all of your dopamine, all of your serotonin. They're keeping those from being ejected from that neuron and causing what would normally be a vasoconstrictive activity, right? So alpha 2 is exactly the opposite of alpha 1 in its activity. It can also cause, because you decrease the outflow of all those neurotransmitters, what it can also do is decrease your heart rate, but not a lot. It doesn't do that as much as it does opens up your vasculature. Your beta 1 and beta 2 receptors, beta 1 we always think about heart, right? We're thinking about this is your inotropic activity, this is your chronotropic activity. You bind those beta 1 receptors and you activate them, heart rate goes up, okay? If you block them, so think beta blocker, metoprolol, labetalol, carvedilol, any of your lols for the most part, esmolol, any of those, you bind that beta 1 receptor, you drop your heart rate because you're blocking the ability for other neurotransmitters to get there and cause an activity. Now, after this presentation, the vasopressor thing, we're going to talk about some antidysrhythmics. So we're going to talk about all of it. Antidysrhythmics and antiarrhythmics. I'll tell you why I call it something different here in a second, or actually when we get to that presentation. But we're going to finish up with the vasopressors and inotropes first. Your beta 2 receptors, we think about those being in the lungs, right? That's why we use albuterol. You use beta 2 agonists. So anything that binds beta 2 is actually going to cause, theoretically, at least in the majority of our patients, we think about it causing bronchiolar dilation. There are some instances where you have the beta 2 receptors in the vasculature, and when you bind those, you also get vasodilation, right? From here to here. So you have to be careful sometimes when you use those because you may end up getting something that you don't want in a patient that's already a little bit hypotensive, okay? All right, so again, we talked about these specifically, but the beta-1 receptors are a little bit different because they're in the SA and the AV node. They work when you stimulate them or block them. It's primarily in that AV nodal tissue, and you're changing the ability of that set of cardiac tissue to repolarize and have the ability to create a myocardial contraction, right? It's not going to create that impulse because you can't repolarize it as easily. We'll talk more about that in just a little bit, but that's how beta blockers actually work. So just looking at it from in general, this is sort of a picture of the vagus nerve and the sympathetic innervation of the heart, right? So the SA, the AV node, gives you kind of an idea of what binds where and how things are actually going to work, all right? This is what those nerves are looking like. So these over here, oh, it does work, good. I'm used to being at places that have TV screens and the pointer does not work. So this nerve up here, this is in your sympathetic nerve division. Ignore the one in the middle. We're going to talk about this one at the bottom and this one at the top to start with, okay? So it doesn't matter which ones we're talking about, whether it's sympathetic or parasympathetic. Over here on this side, this is basically your spine, and it's coming out, okay? So these are your presynaptic neurons. This little gap right here between this one and this one, that's a synapse, okay? It's also, you could call it a ganglionic neuron, whatever. But the idea is it doesn't matter. The ones that are coming from the spine, all of these are associated with acetylcholine, right? So acetylcholine binds to this other nerve and causes an effect. But once you get down here, this little red or pink ball, whatever you want to call it, that's the organ that's going to be affected. So is it a vessel? Is it the heart? Is it the lungs? Whatever it is, okay? We're going to make this really simple because we all know that the heart is innervated pretty significantly by the sympathetic nervous system, so adrenaline, and the vagus nervous system, which is parasympathetic, so you get acetylcholine to bind from that perspective, right? So this will be the adrenaline one, and this one is the vagus one, all right? This is the vagus nerve. So this is the heart, and that's the heart. Again, skip this one. Pay no attention to it right now. It's not even there. So up here in the sympathetic nervous system, that's where you're looking at using things like norepinephrine, and you're looking at epinephrine and dopamine and serotonin. That's where those bind, all right? Acetylcholine doesn't do anything for these receptors. It does absolutely nothing. They won't bind it. It's having the wrong key for the wrong lock, all right? It just doesn't work. So it doesn't matter how much acetylcholine you throw at it, nothing's going to happen. But you throw some...
That's really bad.
But you throw norepinephrine or epinephrine at it, and this receptor is actually going to do something, okay? So this is the postsynaptic neuron, right? Whoa, wrong way. So postsynaptic neuron is this one. And the idea is that at this effector organ, you can bind and get a response, all right? Again, from the sympathetic nervous system. And this is where the majority of your vasopressors and inotropes actually do their job, is within the sympathetic nerve division. We don't talk about the parasympathetic very much, right? The only time we care about or talk about the parasympathetic nervous system is when we end up having a patient that has too much acetylcholine and we start using atropine, right? Atropine blocks acetylcholine. And by blocking acetylcholine, it allows for more effect from the sympathetic nervous system. So that's why you may get an increase in your heart rate or an increase in other things when you give atropine. Because the vagus nervous system or the parasympathetic nervous system usually slows things down. Okay, that's at least in the heart. That's kind of what it's doing. All right. So all that's important because these are classified as sympathetic nerves and parasympathetic nerves. And the parasympathetic nerves in the heart for the sympathetic nerve, those work opposite each other. They're like a yin and yang. So they're always working in concert or sort of against each other to kind of get everything in the right frame of mind and everything going in the right direction. Okay, whether you want to be tachycardic or bradycardic, they all kind of work together. And if one of them is out of balance, then the other one will have a predominant effect, and that's when you can have some pretty negative effects, AV blockade, or you can have tachycardia, tachydysrhythmias. So that's kind of how those things work. But there are times when patients are exceptionally ill, in the case of sepsis, or in the case of, let's say that they have, for whatever reason, they have an intrinsic heart block, whether it's a first degree, a type 2, let's say it's a first degree or a second degree type 1 or 2, or a third degree heart block, right? So atropine only works on those, for the most part, that are above the junction, right? So we're talking about first degree, maybe second degree type 1. Second degree type 2 and third degree blocks typically won't respond to atropine because they're below the junction, so below the AV node, where atropine would actually have the ability to increase the amount of impulses coming through and allow for more impulses to get through and to give you a better contractility. So that's why atropine may or may not work. It's also why if you increase the number of beats that get through the AV node, it's sometimes why atropine can make your third degree block worse. Because the more that get through in a third degree block, the more that are going to get blocked, and sometimes they're going to block them all, and you may not actually have any response. So your ventricles are doing their own thing. Sometimes it makes it worse. But there's always the opportunity for electricity, right? That's one thing. If that doesn't work, let's say for whatever reason, your pads don't work, what do y'all use, Zols, Phillips, Zols? Okay. So let's say your Zol, for whatever reason, will not turn on. I don't know if it's the battery, you got a bad battery, it's cold, whatever, doesn't matter. The idea is you can use chronotropic or inotropic drift, right? That's where those sympathetic neurons come into place, epi and dopamine. Now you're looking at finding those beta-1 receptors and increasing your heart rate and potentially increasing your blood pressure from two mechanisms. One, increasing the force and speed of contraction. You increase the speed too much, don't get what you want. Increase the force and the speed, often you'll get what you want. Now, speed too much, tachycardic. Speed from 30 to 65, good job. That's what you want, right? So that's kind of why these are important and why we're talking about these to start with. But let's talk more about some drugs, right? Let's talk about from the perspective of what do you do naturally? This is the natural progression of how each and every one of us make catecholamines endogenously, right? So what happens is you take tyrosine and then you take tyrosine and manufacture dopamine from, or dopa, it's actually L-dopa, which is levodopa. Then you make dopamine from that, then you make norepinephrine, and then you make epinephrine. And all this happens, right here, right there at the end of that nerve. So it all happens in those nerves. Now there is some of it that also happens in the adrenal glands, but it also happens here, right? So the cool thing is you're making all your own epinephrine and dopamine and norepinephrine, and those are all endogenous catecholamines, right? So those are things that we're all familiar with because we've heard about them, we've used them, and we have them in our own, we're producing them ourselves, okay? So let's talk about the drugs and how we're going to use them to benefit us when we have a patient that isn't well, okay? So we're going to talk about this in the way that, not in the way that we manufacture them. I used to do it in that hierarchy or that order. We're going to talk about them in the way that they are typically administered or in the algorithm of sepsis, right? So what we typically do is start with norepinephrine. This is usually the initial drug that is started for patients that have septic shock after you've given them fluids. Remember this, none of these drugs are useful if the tank is empty. It doesn't, so basically it's the same as y'all turning on the hose and not having any water. Doesn't matter how small the orifice is for the water to come out, it ain't coming out. So that's the deal. So norepinephrine, you can squeeze all you want, but you've got to fill up the tank first. Now, norepinephrine has a couple of different things. It works on beta-1, alpha-1, and alpha-2. So those three receptors in the catecholamine setup, so the sympathetic receptors, right? And remember, alpha-1 is vasoconstriction. That's what it does. It causes vasoconstriction. When you activate it, when you block it, it causes vasodilation. So it also works on alpha-2. Well, wait a minute, hold on. I told you that alpha-2 causes potentially vasodilation, right? And decreased heart rate. Its alpha-1 activity is so much stronger than its alpha-2 activity, you don't have to worry about that part of it. All right, it overcomes its alpha-2 activity far and beyond what it would ever actually create in the patient. It does have some beta-1 activity. right? So you can see an increase in your heart rate. You can see an increase in the inotropic and the chronotropic effect from this drug. That's not why we use it. You don't see people started on norepinephrine to increase their heart rate or increase their contractility. That's not why we start norepinephrine. We start norepinephrine to increase the vasoaction, the vasculature and its constriction. That's why we start it. It's not the only effect we get, but it's the primary effect that we actually receive from norepinephrine. All right, so this is a couple of really small, really simple stick model and sort of a diagram of how it looks. These are some of the primary reasons that we use it. We use it for just about everything in the hospital. This is the primary or go-to vasopressor in the hospital. We use norepinephrine a lot. That's what we use most commonly. So again, it has alpha 1, alpha 2, beta 1 effects. Now, you'll notice that it doesn't have beta 2 effects, right? That's the thing it doesn't have. And we'll talk about that in just a second, how you can remember this versus epi very simply. This is how long it takes, a couple minutes for it to actually do its thing. So 1 to 2 minutes for it to have an action or activity. It'll take a couple of minutes for it to wear off. So we don't use this as, unlike epinephrine in the case of ACLS, we don't administer this as a bolus. We administer this primarily as a continuous infusion. It's not a bolus kind of drug. That's not what you're wanting. You're wanting a more sustained effect over a longer period of time. So we always run these as continuous infusions. The way that we do that is we titrate it to whatever effect we want. The typical dose range that you will see or we will use is somewhere between, I know what it says up there, it says 1. We have to put a 0 in there so that the nurses can titrate it all the way off if the patient doesn't need it. So 0 to 30. 0 to 32 is a much easier set of math to do because 32 is a multiple of 4. And if you put 4 milligrams in something, it's way easier to do the math up to 32 than it is 30. So the whole point is that you can increase this to basically 32 mics per minute. Now, does that mean you can't go higher because they're going to explode? No, doesn't mean that at all. What it means is that if you get to that range, the amount of vasoconstrictive activity that you have is unlikely to be enough by itself. You're probably going to have to add another agent. And the idea is, this is sort of a reminder for us of, okay, you're not winning the game with this alone. You may want to do something else, add a different agent, help yourself out. Leave this where it is, but add something else to do what you want. Okay, that's the goal. Here's some of the adverse effects. Now, interestingly enough, the first one I listed for cardiovascular is bradycardia, right? Brady dysrhythmia, bradycardia. And here's the deal. The reason that you get bradycardia is physiologic, and it has nothing to do with its pharmacokinetics or pharmacodynamics other than if it's super good, really, really useful at creating the vasoconstrictive activity that you want, you get an increased preload. You actually also get an increase in your SVR, right? So your systemic blood pressure increases. What happens is you have baroreceptors that are pretty smart. Your baroreceptors say, hey, we have a great blood pressure. Well, what does that tell your heart to do? Your heart says, oh, I've got a good stroke volume, I have a good blood pressure, I can keep the same cardiac output because my stroke volume's higher, I can decrease my rate. So you get a reflex bradycardia. That's what it actually is. And it means that the drug's doing a really good job of increasing your systolic blood pressure and your MAP. Okay? You can have some dysrhythmias associated with it, and that's because of the alpha 1 or the beta 1 effects. So it does bind to beta 1, but again, it's not the more common thing that you see, and you don't use it for that effect specifically. Tissue necrosis, that happens when it gets outside of the vasculature. So if it infiltrates, extravasates, that kind of stuff, that alpha 1 activity, well, you have a lot of alpha 1 receptors and a lot of blood vessels and a lot of capillaries in your muscles. So that stuff just bathes your muscle and those alpha 1 receptors and alpha 1 constricting drugs. Well, if you constrict it enough, you get necrosis because you have absolutely no blood flow to that area. That's how you get tissue necrosis. The other way you get tissue necrosis and digital ischemia is when the drug's doing its job. It's very much like frostbite. What happens is you will constrict those smaller blood vessels in the very distal areas, and try to preserve moving your way up the larger blood vessels and the areas closer to the core. So lots of times the fingers and toes will turn purple and mottled when we're using this drug, simply because you're basically shunting everything back to the central vasculature, because that's really where you need it, right? When you're dying of sepsis, you're not so much worried about your fingers, toes, and nose. You're worried about your kidneys, lungs, liver, and heart, all in your brain. That's important too. So that's kind of what happens. It's really good at what it does. So if that doesn't work, at least the way that it used to be described in the septic literature for sepsis, was the next thing that you would add, or you could use this first in lieu of norepinephrine, is epinephrine. Well, we're all familiar with epinephrine. Everybody in here is given epinephrine, I'm sure. You all know what happens when you give it. You all know how it works, right? So these are some of the reasons that you're going to give epinephrine over here on the left-hand side. That's sort of what epinephrine looks like, and you can see that it's only slightly different. I don't expect you to be able to pick out the different colored little balls on the bottom there and see how it's different from norepinephrine, but it's slightly different. And we use it for all these different things, but primarily the top 4 are the ones that we use it the most for, as well as in sepsis. We don't use this one as much in sepsis because we often skip over it because of the tachydysrhythmia that it can cause. And everybody here that's given epi has seen the epi pulse and the epi pressure, okay? So even with a continuous infusion, you can see some of those same manifestations, usually not quite to the degree that you see when you give push dose epi in a code situation, but you can still see it, okay? So what you're looking at is alpha 1, alpha 2, beta 1, and beta 2 activity. So the difference between epinephrine and norepinephrine is a couple of different things, but you have beta 2 activity in epinephrine that you don't have in norepinephrine. All right. The other thing about it is the activity of epinephrine at the beta 1 receptor is higher and better than what's in norepinephrine. So many times you will use epinephrine not just for the alpha constrictive properties that it has, but also for the chronotropic and inotropic activities that it has, i.e. in the bradycardic algorithm for those patients who either can't be paced or for whatever reason you just don't have electricity handy for second, third degree block and you want to increase the rate. That's how you do it, and that's why. Okay, so that's kind of interesting. I told you I'd tell you how to remember the difference between epi and norepi and the beta 1 and the beta 2, right? So nor is a prefix that means without, lacking, or doesn't have. So norepinephrine doesn't have something. Anybody in here ever given a norepinephrine breathing treatment? No. You've given epi breathing treatments. Why? Because epi has beta 2. Epi will work in the lungs, norepinephrine will not. So that's how you can remember what it doesn't have. It doesn't have the ability to bronchodilate because it doesn't have beta 2. All right, so from the pharmacokinetics, it's basically the same. We've all, again, experienced the administration of epinephrine in an ACLS event, and it does work pretty quickly usually. And it can also wear off pretty quickly. It may take a little bit longer for those larger doses, but in the doses we use typically for continuous infusions, a little bit less. It takes a little bit less time because there's less drug floating around. We naturally take care of it with COMT and MAO just like we do with norepinephrine. These are naturally occurring enzymes that break down. COMT stands for catechol O-methyltransferase. MAO is monoamine oxidase. That's just what they do. Okay, they break down catechols and monoamines. So that's really what they do. The dosing, again, we're titrating this to the effect. We're going to give the drug, we're going to start it, we're going to increase the dosing until we get the effect that we want. And whether that's a chronotropic effect or whether that's an increase in our blood pressure, we're going to go to whatever we need for that patient at that given time. Now, the range that we typically use is 1 to 10 or 0 to 10 mics per minute. Now, you can dose this and you will, all these drugs, so another disclaimer, I'm not talking about kid dosing at all. I'm not talking about pediatrics, all right? But I will tell you that just about every pediatric dose is mg per kg per minute or hour or whatever it is. So kids are always mg per kg. Adults, not so much. Now, we usually start at 2 or 4 or 6, somewhere sort of in the middle and titrate up or down based on the response that we get. The way that we make our norepinephrine drips, or epinephrine drips, in the hospital is 2 milligrams and 250 of either D5 or NS. So norepinephrine and epinephrine are compatible with either D5 or NS. You can slam it in either one, doesn't matter. They're not going to get angry. Tachycardia, tachydysrhythmia, digital ischemia, same kind of thing. It's that alpha effect from epinephrine. You can have the same overwhelming vasoconstrictive effects there. Tissue necrosis and respiratory, those are all the same. These are basically the same drug with the difference of the beta-2 activity. All right? Well, what happens if you've given norepinephrine and epinephrine, or either or, and you don't get the response you want?
Electricity.
No. It depends on what the problem is, but in sepsis, no, because you need vasoconstriction. We give vasopressin, all right? Vasopressin is completely different from the rest of these. Vasopressin is actually the same stuff that you have circulating all day, every day, and we also know it as ADH, so antidiuretic hormone. And what it does is two different things. It can cause vasoconstriction. It also causes water reabsorption in the kidneys, depending on which receptor it's binding to at any given time. The V1 receptors are the ones in the vasculature, and those are the ones that cause vasoconstriction. The V2 receptors are in the kidney, and those are the ones that cause reabsorption of water through the kidney and allow for you to have less dilute urine, so more concentrated urine. And that's really what happens with ADH. Now, there are different scenarios where you can have derangements of or lack of ADH. Diabetes insipidus, whether it's central or nephrogenic, is either a lack of or the inability of endogenous antidiuretic hormone to bind these receptors and do what it needs to do. You see central DI, diabetes insipidus, in patients that have had severe traumatic brain injury pretty often. It's also something that patients can have as a congenital abnormality, but we see it more commonly in those patients that have had traumatic brain injuries. So from this perspective, it does two things that you want, right? What did I say the first thing was for sepsis? Fluids, and then probably some more fluids. Once you get all that done, then you're going to start with vasopressors. Well, this helps you to reabsorb fluid if you are having a lot of urine output, or even if you're not, it decreases that urine output to some degree because it causes the reabsorption of the water. So it may help to keep the tank full or fuller. The other thing it does is it causes that vasoconstriction with the V1 receptor. The interesting part about vasopressin is that unlike your catecholamines, all your catecholamines, whether it's dopamine or phenylephrine, phenylephrine is not actually a catecholamine, but it works similarly. But dopamine, norepinephrine, or epinephrine, they don't like to be in an acidotic medium. Well, one of the problems with sepsis is that most of the time your patient has lactic acidosis because of hypoperfusion and anaerobic metabolism. Well, most of their pHs are somewhere less than 7.2. That's not what you want. They're less effective in that milieu than they are when you have a normal pH. Vasopressin doesn't care. It's more than happy to do its job in an acidotic medium. It doesn't really matter for it. The other thought is that there is some component of vasopressin that might sensitize the catecholamine receptors to the other catecholamines. This is not a catecholamine, but it may help them to function more effectively. Sir?
So if someone presents to the ED with severe sepsis, this is going to be your guys' first choice?
Second line. Norepi's always the first.
Right.
Because what you have to do is prove that it's not going to work, really. But based on the way that the algorithm has been written and the studies and how they were done, vasopressin is always an additive or adjunctive agent, never first line. Norepinephrine or epinephrine are typically always your first line. So, good question. Based on what I just told you, that's a very logical thought process to say, oh, well, let's just start here. Makes a lot of sense. But that's just not how it was studied, and that's not how it currently. Because the other part about vasopressin is it's a fixed dose. You don't titrate it. You turn it on, you turn it off. That's kind of how it works. Onset's pretty fast. Peaks in about 15 minutes. Its half-life's about 20 to 30 minutes. Its duration's about 20 to 30 minutes. Its half-life's about 10 minutes. And for those of you in this room that are old enough to remember when we used to have vasopressin in the ACLS algorithm, that's definitely me. I remember that quite vividly. The issue is the very first time it showed up, was way back, and they said you could substitute it for the first or second dose, but you had to wait for 10 minutes. It's the half-life, and that's where that came from, okay? So that's why you had to wait. It wasn't because of any badness or any other horrible thing that was going to occur. They figured it was going to last that long, and that's actually how it was studied. So just historically, it means nothing to us now, but historically, that's where that came from. This is your dose. I said that we started at a dose and don't titrate it. There were studies done at all the different ranges, 0.01, 0.02, 0.03, and 0.04. 0.03 is the dose that we use. 0.04 is the dose that you can max out at. There are some studies to support its use. The original studies were done in Belgium, and they actually went up to 0.06. There were more adverse effects in those patients that had those higher doses. Doesn't mean they didn't do well. It just means they had more adverse effects. They found that the sweet spot was right about 0.03. So that's what we use. For DI, that's the IM dose. And again, we don't titrate it. We start it, and it's on. You can have some dysrhythmias. You can also have some angina associated with it. From an endocrine perspective, hyponatremia. And that's because you're not making as much dilute urine. You're reabsorbing a lot of the water. So it's just solute and fluid. That's all it is. You're keeping more water in. Therefore, you have what looks like a dilute amount of serum. So your sodium looks like it's lower. But it's really a hypervolemic hyponatremia is what it is. Tissue necrosis, same kind of thing. Pulmonary edema, well, if you reabsorb water and you keep water on board, it's the opposite of Lasix, basically. You can have pulmonary edema. Bad plan. So, we've used 1, 2, 3 drugs, and we still don't have what we have. We have a really sick dude, okay? This patient is not doing well. So what do we add next? Well, again, the problem in sepsis is typically vasodilation, and it's secondary to immunomodulators, and you're trying to overcome the amount of inflammatory mediators and immunomodulators and all this other stuff that's causing this amazing amount of vasoconstriction with drugs that are supposed to cause vasoconstriction. All right? We have a lot of vasodilation. We're trying to cause vasoconstriction. Now, this drug is very useful in a lot of ways. Phenylephrine is useful for hypotension. It's used for, so you can also use this in patients that have, it's a vasoconstrictor. So Visine, that's basically what this is, right? Or Afrin. Afrin is oxymetazoline. Basically all you're trying to do is you're trying to decrease the volume or size of the tissue so that you don't have as much swelling or edema. So Visine, red eyes. Well, the eyes are red because the blood vessels are dilated. You put this stuff in there, shrinks down the blood vessels, your eyes aren't red. That's how it works. So ideally, this drug is used for I want squeeze. That's all I want. That's all I care about. Alpha 1, I want squeeze. And that's what we use phenylephrine to do. You have to be careful because sometimes this drug is really, really good at what it does, and it will also cause that reflex bradycardia. And in some patients, you can't afford that reflex bradycardia. Now, y'all are all looking at me like, well, this is dumb. Why don't you start here if you want vasoconstriction in a patient that's septic? Well, the answer is because it hadn't been studied that way, and norepinephrine and epinephrine have actually shown mortality benefit when they were initiated first. But again, we haven't started with this one. All right? So the goal is vasoconstriction. This drug's only job in life is to cause alpha-1 binding and vasoconstriction. Okay? Onset, pretty fast. So you notice that all these other things have numbers associated with them. I have looked and looked and looked at multiple different references, and the best I could come up with are rapid and immediate. There is no definition for rapid, nor is there a definition for immediate. It's just fast. That's all I can come up with. Okay? So that's what's there. Duration, 15 to 30 minutes. I can tell you from experience that there are multiple patients that as this drug runs dry and we are trying to hurriedly get another continuous infusion up to the patient and the nurse, that they will drop their blood pressure precipitously after less than 5 minutes. It's patient specific. Okay? That's a general rule. This one's different. It's metabolized hepatically. And remember I told you it's not a catecholamine. So the COMT and the MAO that are endogenously floating around taking care of the norepinephrine, epinephrine, and the dopamine, those aren't going to take care of this because it's not a catecholamine. It's very similar, but it's not. And this is the first thing that we've talked about so far that's not endogenous. You don't make this. This is all coming from a lab, and this is all something that we have to manufacture in order to use. Everything else, naturally occurring. Again, we titrate it to effect. Our typical dosing is somewhere between 0 and 320 mics per minute. We typically put 40 milligrams in 250 cc's of NS or D5. Again, compatible with either one, doesn't matter. And then we'll titrate it up till we get what we want. All right, well, so now we have a lot of different drugs on board. You can see that the same adverse effects are here: the reflex bradycardia, restless excitability, and that's sort of just from an irritability standpoint as well as from a cardiovascular and CNS standpoint. Decreased perfusion, and really what that is if you get enough vasoconstriction, you can decrease the amount of blood flow that gets to your organs, specifically your kidneys. Your kidneys are kind of fragile to a degree. They're also really resilient. You can bang them up pretty good, and then they'll recover. It may take some time, it may require dialysis, but they'll recover over a period of time in most healthy people. They're also some of the first and most reliable indicators that your patient is dry or hypoperfused, because they stop making urine, and they do that pretty quickly. Because here's the thing, of all the organs that you own, the two that you really don't have to have, and your body's smart enough to know this, are your kidneys. You gotta have your liver, you gotta have your heart, you really need your lungs, and you really need your brain. So when things start getting shunted away from stuff, the kidneys are one of the first ones that get shunted from, okay? All right, now, we're on to our fifth drug, dopamine. Dopamine used to be the drug of choice in sepsis. It was the #1 drug. We're going to use dopamine, and dopamine is going to fix everything. So that has changed, and it's changed based on quite a few studies. And what a lot of these studies show, now remember, this is sepsis. This is not ACS. This is not bradycardic algorithm. This is not CHF. This is not those things. This is sepsis. Dopamine was found in multiple sepsis studies to have a higher incidence of mortality compared to either norepinephrine, epinephrine, or norepinephrine and vasopressin, or epinephrine and vasopressin versus dopamine and vasopressin. So they kind of looked at them all together. Dopamine, patients receiving dopamine had a higher incidence of mortality. So they did not do as well. I don't like dopamine because dopamine is a dirty drug, all right? I didn't like it before the studies. I don't like it now, but I don't get to be too choosy. However, dopamine has a lot of different things. When I say it's a dirty drug, it has a lot of different effects at alpha-1, beta-1, beta-2. You also have effects at D1 and D2. We ain't talked about those. What are those? That's dopamine 1 and dopamine 2 receptors. No, those are located primarily in the renal vascular beds. And when you bind them, you cause dilation, and theoretically, you will increase the amount of blood flow to and through the kidneys in those renal vascular beds, all right? So a lot of us remember a long time ago, and even in the relatively recent past, people would say, start renal dose dopamine. Well, that's what they were talking about, is the dopamine dose that everybody was taught will cause that effect and that effect alone. Now, we're going to talk about it in just a second because we're going to talk about dosing. Onset's pretty fast. Everybody here has probably hung dopamine at some point. Yes? No? Okay. Well, we'll talk about all that in just a second. Now, metabolism, again, this is an endogenously occurring drug. We will see a very short half-life. It has a pretty short duration. Once it stops, it stops. The patients will usually deteriorate if they actually need it. Onset takes about 5 minutes, so you don't really titrate any faster than every 5 minutes or so. Got to give it time to do its job. So this is the way that most, at least people as old as I am, were taught that this is how dopamine works. Now you can change the numbers, I don't care. 1 to 5 versus 1 to 3, 5 to 10 versus 3 to 10. Okay, I was taught 1 to 3 and 3 to 10. Either way, it doesn't matter. So that we'll use 1 to 5 because that's what it seems like most people have been taught. 1 to 5 mics per kg per minute has dopaminergic activity alone. So once you get up above 5, so 5 to 10, now you're talking about beta 1 and beta 2 activity. All right? And what we were taught in school was that overcomes the dopaminergic activity, and this is really the only activity you get at 5 to 10. 10 to 20, that's where you get the alpha activity. That's where you get the vasoconstriction. All right? So above 10, you theoretically don't have, at least what we were taught, and I'm going to dispel all of this in a moment. What we were taught was you have alpha 1 activity. So you get vasoconstriction, right? Okay, so who here believes the drug is that smart? I don't. I guarantee you it's not. Anybody that's ever hung dopamine and hung it more than on one patient knows that you can have any and every one of these effects. You can't really define the dopaminergic effects. You can have any and every one of those effects at any and every one of those doses. I have seen patients become phenomenally tachydysrhythmic on 2 mics per kilo per minute of dopamine. I have seen patients have an increased blood pressure up to a systolic of 110, 120 on 2 mics per kilo per minute of dopamine. This drug will bind all of those receptors irrespective of the dose that it has. Every patient will respond differently. This is not how this drug works. You titrate it to effect based on what you want. And the higher you get, the more likely you are to have a significant amount of cardiac dysrhythmia. So the higher the dose, the more likely you're going to get in the 120s, 140s, 160s for your heart rate. Just about guaranteed that if you have a patient that has a responsive heart, they will become tachydysrhythmic. All right, they will become tachycardic at some point. So this is one of the problems with dopamine is a lot of people were taught this and they go by it. Well, I'm here, this is what's going to happen. I'm here, this is what's going to happen. You can't really do that. If you're going to use it, you have to be able to titrate it. That's evidenced no more obviously than the fact that when you look at the AHA guidelines for bradydysrhythmia or bradycardia, what's the range for dopamine for chronotropic activity? 2 to 20. How much is that different from that range? It's not. And what are you trying to do? Increase your heart rate. 2 to 20. So this is not how this drug works. It will work irrespective of the dose based on your patient's response. You also don't lose the activity of the other things when you get to those higher doses. You still have dilation of those renal vascular beds. You still have cardiac activity when you're at the high dose. You definitely get the alpha 1 activity at the lower doses. Okay? So you just have to be aware of all this, and this is not necessarily the way that this drug always works. So that's another reason dopamine is just not the easiest drug to use, nor does it always have the best response or the best outcomes. Okay. Ectopic beats, tachycardia, hypotension, headache, nausea, vomiting, dyspnea. So the nausea, vomiting is kind of interesting. Dopamine is actually a pretty potent emetic substance. So significant amounts of dopamine, circulating dopamine, can cause pretty significant emesis. And that's one of the reasons that we had to change the way that we dose some of our anti-Parkinsonian meds, is because of all the emesis that was being experienced by the patients because of the free circulating dopamine. So, dobutamine. All right, this is the other one that is not part of the endogenous catecholamine tree, and it's not a catecholamine in and of itself either. The thing about dobutamine is this drug is useful for those patients that have significant basically CHF or any other kind of cardiac dysfunction, because what it does is solely associated with beta activity. Its 2 binding sites are beta 1 and beta 2. All right? You don't use it for those patients that have bronchodilation. You don't need it, or you don't use it for those patients that need bronchodilation. What you end up having is a patient that has cardiac output issues and patients that end up needing increased chronotropic or inotropic activity. You say that.
Thank you.
Down going.
Thank you.
1011070. What was that last night?
All right, so the beta 1, beta 2 thing. We're looking at beta 1 activity for the chronotropic and inotropic activity. You get more inotropic activity than you do chronotropic. So you get more force of contraction is really what you're looking at. You get less cardiac dysrhythmias or tachycardias associated with dobutamine than you do with dopamine. The trick is because it has that beta 2 activity. Remember I told you that there's a little bit of beta 2 activity in some of the vasculature. When you bind those beta 2 receptors in the vasculature, you have vasodilation. So we've spent all of our time in this algorithm going from norepinephrine, which causes vasoconstriction, to epinephrine, which causes vasoconstriction, to vasopressin, which causes vasoconstriction, to phenylephrine, which causes vasoconstriction, to dopamine, which causes vasoconstriction. Now we're going to give a drug that causes vasodilation. That doesn't seem like a real smart thing to do, unless you absolutely don't have a choice. And what you really need is a patient to have an increase in their inotropic activity. So we are very, very, very leery of using this drug, and it has to be just the right patient. So onset's 1 to 2 minutes, duration's about 10. Again, this is not a naturally occurring substance. It's metabolized through the liver. The liver is great at detoxifying you. All of these drugs So, all these drugs are considered by your body to be toxins if they're not endogenously occurring like the other ones, and we have things to manage them. So your liver is responsible for getting rid of all toxins, i.e. drugs. So that's why this goes through the hepatic cycle. So half-life's a couple of minutes. We have patients, we don't really have that many in this community. Where I originally trained, I trained in Memphis. So as y'all can tell, I don't sound like I'm from here. If y'all are having trouble understanding me, I'll be happy to repeat anything you want. But the whole idea is we would take this drug and we would put it in these little cassette things. And they're about the size of our cell phones now. And we'd fill them up with dopamine, and we would send them out of the hospital with them, and they would have a continuous infusion of dopamine so they could walk around and actually do stuff because their heart failure was so bad. It allowed them to move. It was awful for those patients. That was the way that they were able to just get through life. So they were able to go home in a lot of cases, but they couldn't move very well, nor could they move very quickly. But that's really its only niche, is in those patients that have horrific CHF and or need a significant amount of increased inotropic activity. That's really where dobutamine has its role.
Are they, for those patients that were on that continuous dopamine infusion, is there like a certain goal they have every day to keep themselves with enough fluids? Because they can't be on a pressor, right, if they don't have enough fluid in the pump.
Interestingly enough that you say that, it was the only drug that we use. And if you think about CHF, really what you want is to run them a little bit dry. Mm-hmm. So they were more likely to be on Lasix or something else because this is not, so vasopressors have to have vasoconstrictive activity. So either alpha or V1, this one doesn't. So it's not technically a vasopressor, so we're not as worried about tanking them up as we are about keeping them a little bit dry, okay, especially in CHF. So again, that's kind of the problem with this drug, is this one is going to work against us from a vasodilatory versus a vasoconstrictive standpoint. And the other thing about this one is, so you think about CHF, you think about either preload, so you think about either afterload responsive or preload dependent patients. So a lot of these patients that we're talking about with the pumps at home were afterload responsive. So when you put the dobutamine on, they not only had an increase in chronotropic and inotropic activity, but they also had a slight dilation on the arterial side, which decreased the afterload, which allowed a more effective forward flow of blood because it was easier to get it out. So a little bit different, but again, that's why it's super, super rare to see this drug ever used in sepsis. This one or Renown, and it's very specific which patients we would use it in. So typical things that you would see for these. Now, again, this is a little bit older. They've actually not really changed it, but they don't say this anymore as far as this is what you have to do. But this is kind of the way we went through it, and this was originally what they had listed in the Surviving Sepsis guidelines of you start here and go here and go here and go here and go here. Okay? So that's why we went through it the way that we did. And now we're going to talk about, we're going to do some antidysrhythmic stuff, and I'm going to give you all a few minutes break first. So, ketamine is sort of a hot topic for everybody, as we started talking about when I first got here. You guys came in a little after I was talking about ketamine. And so here's the deal, right? So ketamine is a very useful drug. Ketamine has a lot of different stuff that it does. It is an effective sedative. It is a drug that also has some analgesia associated with it. It's a drug that its class is dissociative anesthetic. So it's not classified as an analgesic. It's not classified as a bronchodilator. It is not classified as a sedative. It's not a benzodiazepine. It's not any of that stuff. It is a dissociative anesthetic. So what that means is that the drug, in and of itself, has the ability to take your brain and your body and dissociate them from each other. So basically an out-of-body experience. So you can have maybe some awareness of what's happening, but you just don't care because you have a dissociation between what you're experiencing and what you're actually acknowledging for the most part, okay? So ketamine can be dosed a lot of different ways, but when you start looking at it, this is really what happens with ketamine, right? It's an N-methyl NMDA receptor active drug. So there are other drugs that are also active at NMDA, but we're not going to talk about those because they're illicit substances, not things that we make in the pharmacy. They also have some potential activity with the opioid receptors, and that's where you end up with some of the analgesia that you can experience. There's also some interaction with norepinephrine and some of your other catecholamines. Now, ketamine, in a lot of ways, has been stated as a much safer alternative to a narcotic or to a benzodiazepine. And in some ways, that may be true. Okay? In other ways, maybe not. Because from a sedation perspective, it does a good job. Now, what it doesn't do is typically depress your respiratory drive. Some of the things that it will do that are potentially beneficial in this or any other scenario are creates analgesia, as evidenced by this to some degree. It actually causes bronchodilation. One of the patient populations that we've used this drug in for a very long time is asthmatics. Status asthmaticus responds very well to ketamine infusions many times when albuterol continuous infusions or other beta-active drugs don't work, or when your mag drip doesn't work, or any of those things. So from that perspective, we've used ketamine for a long period of time. So it also potentially is hemodynamically stabilizing. And what I mean by stabilizing is it doesn't cause hypotension. If anything, it will cause hypertension. All right? And the reason for that is some of this catecholamine release and some of these other activities that you can see listed up here, especially with the norepinephrine and serotonin and those kind of things. So you can have this catecholamine release that will potentially cause hypertension and tachycardia. There's also the potential that this drug can cause an increase in ICP. Most people have decided that that's not really an issue at this point and that they aren't overly concerned about it, but that is something that was originally placed in the literature. One of the things that we have to look at is why are we all of a sudden using ketamine? Why didn't we use it for a long time? Well, one of the reasons we haven't used it for a long time is when I was in pharmacy school, 15 years, no, I've been a pharmacist for 16 years. So when I was in pharmacy school 20 years ago, we'll say that. Well, what they told us was this dissociative anesthesia kind of thing, part of the issue with that is when you wake up, you can have emergence hallucinations, all right? And emergence hallucinations are when you emerge from the induction of anesthesia or the very large doses of ketamine that are given in that scenario. You many times as an adult, is the way they told us, will have hallucinations, some of which could be horrific. So because of the opportunity for those emergence hallucinations, this drug was relegated to kids under the age of 5 and veterinary medicine. So they've used it in veterinary medicine for a very long time because dogs, cats, horses won't tell you that they're hallucinating. They may still actually have those unfortunate side effects, but from an induction standpoint, because of all the other things I said about it, it's a very useful drug for everybody, right? The lack of loss of, basically the loss of your respiratory drive, the bronchodilatory properties, the hemodynamic stabilizing properties of the analgesia. All of those are good things. So what you have to look at is, okay, we've decided that now some of those benefits may outweigh some of those detriments. The other thing that anesthesiologists kind of figured out was if you give a little bit of benzodiazepine, like a milligram of Versed, most of those emergence hallucinations don't happen. Now that's what the anesthesiologists have taught me. We don't use this drug a lot as a continuous infusion or as a drug for RSI. We do use it, but not a lot. We have a lot of other things that we use, plus we have a lot of other, right or wrong, we've got a lot more support than y'all do. We have anesthesia next door, we have glide scopes, we have people that get airways all the time, we got surgeons that'll put a trach in. We use a lot of different things, right? So this drug is used less commonly, partly because it lasts for a little bit longer. And also because we don't really need, in a lot of these cases, the hemodynamic activity. And when you're doing RSI, one of the things that you don't want, but can happen with this drug, laryngospasm. That's one of the rare, really negative side effects is laryngospasm. Now, once you get that, now you're kind of committed to parenteral treatment. So,
Well, is there a specific dose range that'll happen, or is it just random patient to patient?
as far as the hallucinations or the laryngospasm?
Range of that.
It's, from what the anesthesiologists have told me, I personally have never seen it, okay? What I've been told is that it usually depends on the speed that you give it,
Okay.
not necessarily the dose, but I honestly don't know. I know that you can give really high doses when you give an IM, when you're doing induction. I also know that the pain doses are usually less than the induction doses, whether they're IV or PO, or IV or IM. And a lot of the problem comes when patients don't respond or haven't responded in a relatively quick period of time and a repeat dose is given. And then it all catches up and patients are obtunded and we get them in the ED and then all of a sudden their GCS is 8. Is it ketamine? Is it the head injury? I don't know. We're going to tube them, send them to CT, figure it out. So we've had a couple of patients in the last few years, more than a couple. I'm being a little euphemistic with that have experienced an intubation for 12 hours or so, basically until the ketamine wore off. And then we extubated them the next morning. Now, is that the worst thing in the world? That's not the worst thing in the world, but is it potentially very dangerous? Absolutely. You never want to mess around with the airway unless you absolutely have to. The problem is that based on their GCS, we absolutely had to. We didn't have a choice. So from the perspective of cardiac patients, is it in your cardiac algorithm? Because I would imagine it's not because of this catecholamine release.
And so where I was thinking about it is like, okay, pacing, cardioverting, that sedation period. And when I think about it, I think of, okay, so I have somebody who's unstable, I need to use electricity. obviously I want to keep them as comfortable as I can and sedate them, but I'm a little nervous to use Versed because of the hypotension that could come from it, which brings me to ketamine. However, I do understand that there is that decision you have to make where you say, this person needs electricity first before I give them this medication to sedate him, but Versed has that retrograde amnesia effect.
Correct.
Does ketamine have that effect too? Okay, and correct me if I'm wrong, Scott, but I think we can, in the new protocols draft, we can give some Versed with ketamine, correct?
That's what we want. That's something that's going to, we're fighting Carson for it. They don't want to. So we have two possibilities with it. Putting them on a maintenance drip to avoid reemergence, and we wanted the clearance to give a small amount of Versed with it. We have those drafts out there in the process. They're going to be to the medical directors. We got to talk to them for a few things that we want, because it's much easier probably for us to give a little bit of Versed, or at least have the freedom to. And and then also have the possibility of that maintenance strip for long distance stuff. So that's what we're hoping for. But again, this is gonna be a steep learning curve for us, because we've never had this. A lot of us have never worked for it. We now are having drug facilitated innovation along with this for sedation, along with this for pain. It's gonna be a very steep learning curve.
Because in my mind, like, I like what you said about using like a milligram per Versed, because to me, a milligram, and correct me if I'm wrong, but I couldn't see a milligram having that much of an impact on your blood pressure compared to giving like 5 of Versed. So it was,
Comparatively, no.
but it's all patient dependent.
It is, and you also have to look at your patient's. So when you start looking at your patient, their hemodynamic status is going to tell you a lot about them, and it doesn't matter. So age is one thing, debility is another, and then you have the hemodynamic response, lack of response, or hemodynamic instability anyway. Specifically in the patient that you just described that requires pacing.
Yeah.
However, if they're requiring pacing because you think they've recently had an MI or they have some other issue where they have significantly either A, devascularized, or B, ischemic myocardium, I would stay away from ketamine.
Okay.
Unless it's in your protocol. But
yeah, and
from this perspective, because here's what can happen. You can actually get a pretty significant increase in blood pressure and heart rate. And now we're back to, am I increasing the myocardial oxygen demand over and above what I should be doing? Or am I doing something that's okay? And the problem is, once you give it, you can't take it back. There's no reversal agent for ketamine. There's a reversal agent for Versed. Y'all probably don't carry it, but there's a reversal agent for Versed. And if you're pacing them, it may be the better option anyway.
Okay.
May.
Yeah.
That's a tough one.
Yeah, and like the patient that like sticks out to me is that he's in SVT, he's crumping, we need to cardiovert him. Okay, I'm gonna cardiovert him. Well, that probably didn't feel too good. Let me give him some ketamine and then give him a milligram of Versed. Now I know, hopefully, it's patient dependent, but I'm not gonna drop his blood pressure too much with a milligram of Versed. I gave him that ketamine for sedation, and now that milligram per Versed is also going to help with the reemergence, and it'll give him that retrograde amnesia. But
remember that dose of ketamine, the emergence hallucinations usually come with the bigger doses of ketamine. So the larger doses that you're going to use for potentially for induction or for something else, not necessarily pain doses or smaller sedation doses. I'm talking about like 1 to 4 milligrams per kilogram IV of ketamine.
Gotcha.
So that's usually where you would see it, is in those patients that were emergent from the induction of anesthesia. That's the emergence. Most of the patients don't have the same response to the lower doses, and that's one of the benefits of the lower doses.
Okay.
So I think that's the last slide I have on ketamine. But that was it.
It's gonna be a real steep learning curve.
What else?
A lot.
So what about ketamine for, like we were just kind of talking about, CPAP or even things like anxiety? Is it an appropriate use at low doses for just keeping that anxiety level down, or even somebody that's having an anxiety attack?
I've never seen it used for that. I haven't. Now, we use it for all kinds of stuff, right? There's literature out there for depression, and there's literature out there for sedation. We use it as a sedative in patients that are ventilated from time to time. So we do use it as a continuous infusion from that perspective. Very similar to how we use propofol. We use it in that same vein. You know, it could be beneficial to them, but here's the other problem, right? If that patient does have one of those hallucination episodes, and you've now slapped a CPAP mask on them, that ain't gonna go well. They're really gonna think you're trying to hurt them then. So, from that perspective, or I'm already anxious, because here's the thing, right? I alluded to this. I wasn't gonna bring it up, but that NMDA kind of thing right there, that's also what PCP does. So you got to think about it from that perspective too. That's where you get the hallucinations. So you got to be really careful when you do use this and in what patient population you use it in. Because let's not forget that even though we've had it as a medical agent for a long, long time, and we've used it as a veterinary agent for a long, long time, this is still a drug of abuse on the streets, Special K. Okay? People like that. Some people will have this on board. Some people will use this for those same effects that you can potentially get from the PCP. So you got to be really careful with it. Not that you can't abuse fentanyl and morphine and oxy and all that stuff we use anyway, but this is one of those drugs that has really weird side effects. So.
Do you know what the instances of having a reemergence off a low dose?
I don't. I don't know numbers. I really don't know. We haven't looked at it. I haven't read anything about it because, frankly, I just haven't.
Yeah.
And it's not a good answer, but I haven't read anything, so I don't know.
Fine by me.
Yeah, and I think that, you know, we talk about it, and my wife's a PICU and NICU RN, and she was a flight nurse in Memphis for a long time for a pediatric flight company, but we've talked about ketamine a lot. They use ketamine a lot. They use ketamine a lot in kids that are having radiation therapy and other stuff. So under the age of 5, right? She has a lot more experience with ketamine than I do, but she's told me multiple times, and I believe that the case really is. Remember I told you less than 5? Most kids less than 5 aren't going to tell you that they're having hallucinations. They're just going to have them. And she says that patients' parents hate ketamine because often their kids wake up angry and screaming, and she said she's recovered so many kids that are just reaching at stuff that's not there, and you know they're having hallucinations. And this poor little kid that's 2 or 3 years old that just had radiation therapy is now having hallucinations secondary to ketamine. So I'm going to tell you that it's those were relatively high doses, but I think it's probably pretty common. We don't see it, and our anesthesiologists don't use it very much ever. So the majority of my experience with it is going to be from y'all on the pre-hospital side bringing them to us and us watching them after they get to us, because we don't use it very often. Most of my docs would prefer propofol as a sedative agent, and would prefer, for drug-assisted intubation, propofol and Sux or propofol and rocuronium are the things that we use the most commonly. A lot of my docs will use etomidate because it's hemodynamically neutral, whereas propofol can cause pretty significant bradycardia and hypotension. The issue then becomes, which one are you going to use? And in general, they will use propofol because it lasts for a very short period of time, and you don't have those emergency hallucinations. And a lot of our patients are going to be maintained while they're on a ventilator with a continuous infusion of propofol. So that's another reason that we will choose it. Way off topic from ketamine, but from the experience that we have, that's what we do.
And we're all very interested because most of us have not worked with ketamine in here, and it's something that's in our new protocols, and it's something, I mean, like I said, there's going to be a steep learning curve. Somebody's going to reemerge somebody. There's going to be issues with it. We're trying to identify what they might be so we can train on it prior to it going.
It is a super steep learning curve. Yeah. I know y'all are familiar with and have friends that work for, REMSA or CareFlight or Reno Fire or any of those guys. Talk to some of them that have used it. and find out what their experiences are, and find out kind of where they are with it and what they've been doing, because they've been using it for over a year now, a couple years, and it is still a learning curve. And the problem is that, unfortunately, because we are where we are and we have to do what we have to do, protocolized medicine is great for 80% of people. I mean, it's roughly a bell curve kind of thing, and we're always going to find patients that don't fit quite in that pigeonhole that are going to react completely differently from what we expect, either beneficially or adversely. And it is a steep learning curve. So you're gonna get used to it. You're gonna use it, and you're gonna find out if you like it or if you don't like it, and how much you do and don't like it for certain things. It's just another tool in the toolbox. What I would caution you about is, don't assume that it's going to be the end-all, be-all, and fix all the issues that you want it to fix, because you're still going to remember and need to use Versed and fentanyl. What do y'all have for analgesia?
Percent value.
Probably down the street.
What about-
We have fentanyl. Yeah.
So don't forget about those.
Yeah.
Those are still good drugs and very useful. Gentlemen, be safe.
And we'll still be able to do like a fentanyl Versed combo. if we
Right.
need to.
And
So,
often fentanyl first is the right answer. So,
Thank you very much.
well, see y'all. So,
That's a 1-for-1.
okay.
You take that, or they take it.
What y'all want? What y'all want to do?
Other questions? Come on, Sammy, you're full of questions today.
Dr. Watts, come on.
Come on, Dr.
I'll
Walker.
back to that Brazilian one too. Right?
Tiny dancer. You can stop talking. I'll
What are you guys talking about?
Yes, sir.
Are you like still on probation or?
No, I should just.
They should be.
This is what probation looks like.
Not a word, still.
Yeah, he is horrible at probation, so we're trying to.
And you let him stay?
It wasn't our choice. We wrote letters.
How long is your arrhythmias one?
About an hour.
Yeah, you'd be way out.
So here's the deal. I'll be happy to come back. If y'all want me back, I'll come back.
Yeah, we'll talk to them.
Yeah.
Is there any way we can get, for us that missed the ketamine printout of this, or even just the whole thing, slideshow?
There's this one.
Yeah, I can. So what I'll do is I'll create a PDF of the Pressors one that I finished up while y'all were gone. The ketamine one is 2 slides, so I'll put it in there with it.
Oh, perfect.
And I'll just I'll send it. I'll get your email, or I can
And
do
it's,
this.
it's all recorded. It's gonna be on Target Solutions.
Perfect.
So whatever y'all need,
Okay.
I'll be happy to do that. I'll PDF it and I can send it to you so y'all can look at the slides, because I don't know how much of those are going to be on there. Maybe all of them, but
That should be.
okay.
It's just harder to see on the videos.
Yeah.
The PDF.
Would be nice.
And if y'all have questions, feel free to reach out to me about anything. I'll leave my card with you that has my email and my cell phone and my work phone. So if y'all have any questions, or if it doesn't make sense, because every so often I do misspeak on these, and when I'm getting taped, I'm like, oh wow, that sounded really dumb. So it may have confused y'all, so just let me know. I'll be happy to do whatever you want to do. So, and we can talk about whatever you want to talk about now for another 20 minutes, 15 minutes. I do sort of have to get back to the hospital by sometime this afternoon. But we can do whatever you want, and I'll come back and do whatever you want whenever you want.
You guys got anything?
Hyponatremia.
Just that's like a
simple
3-day
defini-
lecture.
Just a simple definition.
Hyponatremia.
Yes, sir.
The simplest definition of hyponatremia, which is also not correct, is sodium less than 135. Now, the thing about hyponatremia is hyponatremia comes in various forms.
Okay.
Hyponatremia comes as hypervolemic hyponatremia, normal volemic hyponatremia, and hypovolemic hyponatremia. So the trick is, the first thing you got to figure out the volume status.
Okay.
Because a hypervolemic hyponatremia, they may actually have a normal amount of salt, just too much water, right? So you're making Kool-Aid, right? I ain't made Kool-Aid in years, but you're making Kool-Aid. If you don't put the whole packet in there, it doesn't taste right, right? But that's because you got too much water per Kool-Aid. You put the right amount of Kool-Aid in there, the right amount of water, then that's what you want. The trick is, with hyponatremia, if it's hypervolemic hyponatremia, it's the dilute form of the Kool-Aid. It's like when the ice melts in your Coke. That's really what it is. So you have too much free water or free fluid versus the amount of salt that you have. Normal volemic hyponatremia is often associated with a couple of different disease states, but it's truly, in most cases, a hyponatremia. So you don't have enough salt because your volume status is normal, all right? And then the worst of all of them is hyponatremic hypovolemia, or hypovolemic hyponatremia. Because what happens when you become, so let's say that I dump 2 packets of Kool-Aid in here for 1 thing of water. Well, it's super like Kool-Aid, whatever flavor it is that you wanted. That's what happens when you leave stuff out in the sun and evaporation occurs. So if you think about your patient that should have a normal amount of salt, when you remove just water, they should become hypernatremic. Uh-oh, we've removed salt and water, so they're hypovolemic and hyponatremic. They're really down. Because that's really the problem. You've now lost both. And you can experience all of these from different perspectives, whether it be from diuretic therapy, from psychogenic polydipsia. You drink about a case of these a day. You can drive your own sodium down. If you don't ingest enough sodium, that can be another scenario. If you're supposed to be on Lasix, or if you have renal dysfunction, or if you have an issue with I do this because up here about 45 minutes ago was a slide about vasopressin, which has.
So with hyponatremia, are you also looking at interzonal possible dysrhythmias just because of?
You can. Dysrhythmias don't usually occur from hyponatremia until it's really severe. So 125, 126. What you see more commonly is neurologic dysfunction, seizures, things like that when you have significant hyponatremia.
Okay.
Because it affects the brain more. Gentlemen, to say.
Thank you.
So it really affects the neurologic function more than it does the cardiac function. So kind of different, but sort of the same. It's different from hypokalemia or hyperkalemia, which are more arrhythmogenic, less likely to cause a seizure. And it's all based on where it actually has the most activity. And the thing about it is, the hyponatremia. So the hyponatremia, what actually happens is all of your organs, and specifically your brain, are equilibrated to what you normally have as serum solutes, right? So if it takes longer for all of your organs, specifically your brain, to change those different ratios. So if you all of a sudden become hyponatremic, but you still have a normal amount of volume, or even a hypervolemia, what typically will happen, or sometimes even hypo, the trick is what happens is your brain is saltier than your blood. So then what happens is the extra free water from the blood, because there's more free water in the blood, doesn't pull salt out of the brain pulls water out of the blood and swells. You get cerebral edema. So that's what the problem is when you have hyponatremia and some rapid shift in sodium. So that's what can happen. The opposite will happen when you correct hyponatremia too quickly. Brain has an X amount of sodium, right? You correct the serum sodium too fast, guess what happens? Shrink your brain. So the idea is that when you correct it, you want to correct it relatively slowly so that you don't create this central pontine demyelination, which is irreversible because you've changed the osmotic gradient between the brain and the serum too quickly. So what you want to do in most scenarios is, let's say that we're going to say they're less than 120 because that's the number I want to use. So their sodium's less than 120. You don't want to correct their sodium in the ideal world if they have no neurologic dysfunction, no severe side effects, no severe problems. You don't want to correct their sodium by more than about 5 or 6 milliequivalents in 24 hours. So in order to do that and prevent that central pontine demyelination, we will check BMPs often every 2 hours to make sure that the sodium isn't going up too fast. So hyponatremia can be a real problem. And the trick is, do y'all carry istats? So y'all don't know what the sodium is, right? So sometimes the patient may look like they have a hypovolemia or some other issue. What are you going to give them? NS. You're not going to give them D5, you're not going to give them L, well, I don't know. What do y'all carry, NS or LR? NS. All right, so normal human, hyponatremic human, we'll call hyponatremic human. Hyponatremic human has sodium of 120 millimoles per liter, milliequivalents per liter, however you want to call it. Same thing in this scenario. How much sodium only, not chloride, sodium, is in a liter of NS? How many milliequivalents per liter? See, I got eyes up. 154. That's vastly different from 120. So you can do calculations and figure out how much a liter or how many liters of NS you need to correct that patient and how quickly. You start slamming liters in somebody that's 120, 154, they'll equilibrate at some point, and you're going to end up driving them up. Are you going to drive them up too fast? Maybe. You got to be careful? Yeah. Do you know? No. Are you going to do what's best for your patient based on the information you have? Absolutely. That's the problem, right? Patient looks septic, patient looks hypovolemic. You're going to do what's best for your patient. And sometimes, hopefully the transport's short, bad things don't happen. Probably not going to happen. We do the same thing in ED. Before we get labs back, slam them with fluids sometimes. Sometimes that may not be the right answer. But we're doing what's best based on the information given to us. So, you got to do what's best with what you got. So, very good question. Yeah. So, no, sodium management is, because those three things are true of all. So, whether it's hyponatremia, normal natremia, or hypernatremia, you have to define hyper, normo, and hypovolemia for all of them. So there are 9 different ways you can go on that algorithm. So that's why I say that's like a 3-day lecture. Sodium is hard. Sodium is hard enough that we often call nephrology and say, here, fix this. We want somebody smarter than we are. So that's all I got.
TXA in the pre-hospital setting. That's another one we're going to or trying to.
Okay.
A lot of us aren't familiar with.
Okay, TXA. I have a slide. See, I don't have a slide for sodium, but I do have a slide for this. Oh, sodium nitroprusside. Y'all ever use sodium nitroprusside? I just stopped here because it always catches my eye. So here's the problem with sodium nitroprusside, right? Sodium nitroprusside is great for vasodilation because it's a nitric oxide donor, right? So it donates that one nitric oxide up there at the top and causes vasodilation just like nitroglycerin does. What's left? 5 cyanides. Sounds like a great drug to infuse in people, right? It actually works really well, and you don't get cyanide toxic for a few days. Legitimately, the package insert says you probably shouldn't continue the infusion for greater than 72 hours. Here we go. Tranexamic acid, TXA. So I haven't updated this PowerPoint since the Crash 3 trial came out. So this is basically the Crash 2 trial is what we're going to talk about very quickly. So tranexamic acid is an antifibrinolytic. Right? TXA is what we all know and love it as in the medical world. So the idea is that what you're going to do is you're going to dose it. Now, this dosing is for either hemophilia or for, it's actually for hemophilia is what it's for. But the dosing that we're going to use is 1 gram in 100 cc, what we do at the hospital and the way that was studied. 1 gram in 100 cc's over 10 minutes, followed by 1 gram in, you can either put in 500 or a liter of NS and run it over 8 hours. Okay? All of this has to be accomplished within 3 hours of injury. Not 3 hours of you finding them in the desert. 3 hours of when they actually had their injury. Now that's hard to determine unless somebody calls it in because they saw it, right? Or, oh hey, I heard this and maybe that's 10 minutes ago, okay? You roll up on somebody who's just bleeding in a desert, don't really know, maybe it's good, maybe it's bad. Here's the reason I bring that up. In the Crash 2 trial, it showed that those patients that received the drug at a later stage in their injury process had an increase in mortality. So that's not ideal. If you find them in 3 hours, great, do it, okay? Originally, we said don't do it in patients that have isolated head injuries. Now, Crash 3 came out and said you can do that too. It's okay. It lasts for a while. Here's what it does. All right, it displaces plasminogen from the clot and stabilizes clots. Does it create clots? Nope, it does not. Does it stabilize clots that are already present? Yep, sure does. So the difference between this and one of your hemostatic agents is that this drug doesn't, its job is not to increase the activity of the coagulation cascade. The idea is to stabilize clots that have already formed. That's its goal. So this is exactly 180 degrees opposite of alteplase. Alteplase, also known as TPA, last time I'll refer to it as that because AHA says I can't. Alteplase is tissue plasminogen activator. That plasminogen that's bound to those fibrin cross-links, it activates it and it turns it into plasmin, which means that it also makes it able to cleave those fibrin clots, which means that now the clot gets broken down, and if you had a stroke, great. The clot's broken down, and you now have the ability to reperfuse those areas. If you had a PE, PE's gone. Now you have the ability to reperfuse those areas and oxygenate and ventilate. Had an MI, clot's gone. Now you have the ability to distally oxygenate and perfuse the cardiac muscle. Okay? That's how alteplase works. This drug is exactly the opposite. Those clots are going to stay better if you give them this. Now, that's useful if you have a clot that you want in the femoral vein or somewhere next to your spleen or in one of your hepatic arteries because you're trying to bleed to death. That's useful. That's where this drug comes in handy. Now, I mentioned the Crash 2 trial. Very large trial, multi-center, lots of different places, not in the U.S. Was not studied here. Was studied in a lot of different countries, some of them third world, some of them actually developed countries. A lot of different information. The Crash 2 trial was basically a decision made by a physician. Okay? Patient, you bring the patient in, backboard, well, they may not even have backboard. Came into the ED, looked at him, I think he's bleeding, give it to him. That was the decision. Or, I don't think he's bleeding, don't give it to him. Or he has this, don't do it, he has this, do it. Very simple algorithm for how this drug was studied. What they found was that, again, if you had those patients that were within 3 hours of injury, it had a mortality benefit, so less patients died. We started using it because of that information. We started using it a couple of years ago, probably around 3 years ago, probably. We've used it in cardiothoracic surgery, and we've used it in hip and knee arthroplasties on the orthopedic side for years to decrease bleeding. And The dosing is all over the place for that. This is a very simple dosing strategy, 1 gram and 1 gram. So is it useful? Possibly, probably, in the right patient population. Are there things that you can do to assess whether or not your patient may or may not need it? Yeah, when they get to the hospital, but you don't know that, so you're gonna follow the protocol that has it available to you, and you're gonna give it when it's appropriate.
Right.
So, is it gonna hurt them? Probably not. There are some studies that showed that there were some thromboembolic complications associated with it. It's a little bit yet to be determined what the actual benefit versus risk is for the drug.
Right.
In general, it's probably a safe thing to do. Because again, theoretically, all you're doing is stabilizing clots, not making new ones.
Right.
So,
You said isolated head injuries.
isolated injury in crash 2, they basically extracted those. Crash 3 looked specifically at traumatic brain injury. And what they found was patients that had mild to moderate, severe, that was really not, that's one of those misspeak things. Mild to moderate, severe brain injury, that's not how it works. They had mild to moderate brain injuries. Those patients, based on the way that they did the study and what they've reported, did have a decrease in mortality when given tranexamic acid in the exact same way. 1 gram and then 1 gram over 8 hours following. Because of the original trial, we started keeping tranexamic acid in the ED at Renown, so that when they were brought in by the pre-hospital folks and you'd already given them 1 gram, we could just start the drip and call it good. So, because Careflight's had it for a while, and I think CalStar has it, and has for a little while.
Thank you.
You're welcome. So does that help?
Yeah.
Good. And it's